there any need for immobilization after?
No, if it's no need for immobilization due to diagnosis, certainly if I have partial rupture of Achilles, I use immobilization for yes, the same immediately. Or if I have complete lesion of the ligaments, grade 3, so in this moment I use immobilization 5 weeks in cast. Yes, walking cast behind. Not for the injection, for injury. Yeah.
So afterwards we have to go through the practical issues. Do we have any questions from the audience? The guy in blue solved his question directly with Dr. Okay, so as a reminder to all, this is what it can be done. As I was discussing prior to Dr. Pessoa, it's better to do using direct ultrasound to guide your injection, but if you have a superficial tendon, it's possible with the correct knowledge of anatomy to do it without the ultrasound guidance. Either way, because you can do it on your private office, not really needing a specific surgical room for the clearance and the cleaning of the area and the sterilization of the area. So, as I told you before, I addressed the landmarks and the overview of how the STABHA acts. Dr. Lubus talked about how to use the ultrasound to perfect the quality of injection. Dr. Pessoa addresses us with the correct use for treating ligamental lesions of the ankle, which are one of the most common lesions that we have in practicing sport and also without practicing sport. In Brazil, is the most frequent lesion that goes to the OR is the emergency room, is the inverted or reverted lesion of the ankle. And Dr. Fadel, with his greatest experience in Brazil, shows us how to do it correctly with the help of Dr. Lubus with the use of ultrasound. Please.
One more question.
Yeah, sure.
Usually one injection is enough, or do we have to do 2 or 3 of them?
Dr. Fadel, uma injeção é suficiente ou você precisa? He usually do this. Dr. Pessoa?
In that case, what? But
The interval?
is 1 and after 48 hours.
And the interval in between?
Between one and the first and the second?
48 hours.
48 hours.
48 hours.
The same for Dr. Fadel. Dr. Lubus?
It depends on diagnosis. Yes. If we have necessity to put immobilization, it's impossible to do it twice day by day. But if I have also by the grade 3 problems with syndesmosis, I use one as was demonstrated to the anterofibrotalar ligament and another one to the syndesmosis. So in this moment I use 2 in one moment, in the same time. Yes, otherwise one is enough and then I put the plaster.
And there is no need to repeat them after 24 hours?
It's impossible when I
48 hours.
put the plaster.
The major thing is the STABHA is an adjuvant of the treatment. It's not the treatment itself. This must be emphasized. So it's one of the other issues that we have in our arsenal to treat tendinous lesions. So that has to be very clear, because
Just some more comments on top of this. Yes, regarding this, the treatment scheme, I think is very important. That's why I want to come over and make some comments. The product was brought onto the market in 2007, 2008, when that time for the ankle spring, we performed a clinical trial, which is randomized, double-blind, placebo-controlled trial. At that time, the treatment scheme was 2 injections, 48 hours. The first injection was performed, had to be within 48 hours after the onset. Then the second injection, another 48 hours, 2 days apart. That was the clinical trial design that we had to follow up, and we got the product approved with that scheme, treatment scheme. which is in accordance with the clinical trial data that we got. But in reality, in clinical practice, sometimes it's very different. Also, I say sometimes, often enough, it's very different from the clinical trial. Because clinical trial, we have the protocol that everybody has to follow the protocol. But in daily practice, we're so different because of the availability of the patient, because the condition of the sprain. So everything together, we see lots of cases that patients come in after the first injection, then they are very happy. They go away. They don't show up again. They disappear. It's because there's satisfactory results that they obtain. So based on this, we say we see a lot of patients that they receive only one injection, which is sufficient from patient point of view, also from the treating doctor point of view. But whether this is in line with the official approval, well, that remains a question mark, I say, to be debated.
Yes, the perfect world is a bit different from our practical world. So it's very difficult for every one of us to have the patient at least 48 hours right away after an echo sprain. Maybe Dr. Pessoa, who was specifically on the sporting teams, has the chance to access the athlete in 48 hours after the echo. But in our reality, in office practice, it's much more common if the patients can maybe 2 to 3 days later. So with or without any type of treatment. For instance, in Brazil, it's quite common for the patient to go to the emergency room, and the next few days he looks after his doctor and see his correct treatment. Never comes back to the emergency area, and when he comes for the treatment, as Dr. Shan says, he has already done a lot of things that might make some difference in the results, which may not be in line with the approval issues for the regulatory institutions that they apply for the medication. Okay, that's my point of view, which is in line with Dr. Shan. Any other question regarding, please?
Dr. Exner, Czech Republic. I would have a general questions to the panelists regarding the impact of the treatment. We have seen that there is a lot of improvement in terms of the pain and future instability or the prevention of the future osteoarthritis. From that perspective, would you recommend the treatment to everybody developing a grade 2 ankle sprain, or is there a kind of differentiation? Because in the practice, so far, I don't think the product is in a way of the broad distribution. So, clinically speaking, is there a kind of differentiation to whom to put on the therapy and why not?
I would quote a phrase in France: "En médecine comme l'amour, rien jamais, rien toujours." So it's very difficult to say it's mandatory forever twisted ankle. So I would say it's based on the clinical experience of the doctor, the use or not of the substance. This is my personal opinion. I would ask the panelists. Dr. Pessoa, what your thoughts about?
What I say is it works in an athlete. In an athlete, I think we can use it, and you should use it in everyone that have a sprain with this characteristics. Not in grade 1, but the second thing is there are a lot of one thing that it's with me is if there are lateral effects. I didn't saw anything, and the patient is satisfied. So the only thing is now is the cost, and we cannot use it in all the patient. But if you can use it, of course, it's a good solution. We can put it back, because they don't win so much money to go back to the work, but they are losing time. So
one thing that we Professor Exton from the Water Epidemiologist states that the average player, the cost of a 1 day per lesion is 50,000 euros per day of lesion. So in the elite sports, financial issue might not be the big issue. Dr. Lubos, your thoughts, please.
theoretical thing that there is not any contraindication to use it commonly by any patient. But the problem is certainly the price and the availability of the drug, because normally we cannot see it on normal surgical ambulances. And that's the place where these distortions are in the main concentration. Every fifth patient is there with ankle distortion. So, but it's impossible to have this big amount of sport width of in any surgical ambulance or any surgical clinic, and to use it by any patients due to the money and due to the distribution of the sport width or tenderless drug.
Dr. Fadel, would you like to add something about our previous?
The results are promising, and avoiding surgeries or late in surgeries is very, very good to patients, athletes or not athletes.
Yes, please.
As far as this product is for soft tissue, I mean modified for soft tissue, can we use it in osteoarthritis? Second question, can we use it in post-operative arthroscopy?
It's not designed for intraarticular use. Correct me if I'm. Would you like to answer, Caroline?
Yeah, so this product, it's not done for, it was done really for soft tissue injuries. We have another product for osteoarthritis and cartilage, which is called Reneavis or Dualvis, depending in each countries. And this one is composed of high molecular weight and low molecular weight hyaluronic acid. So we have 2 chambers in one syringe. So this one is very focused for osteoarthritis treatment.
That's why I addressed in my third or fourth slide the importance of the molecular weight of the substance, because it's related to the rate of absorption and the spread of the substance in between the matrix of the tissue. Dr. Lewis?
Maybe I can add, there are also some special cases when we have to join the osteoarthritis and soft tissues in surroundings. For example, it's arthrosis, when I put sometimes the sport vis and I put a part in the surroundings of the arthrotic joints because it's very painful, into the bursa above, and a part I put inside the joint. Very similar situation is if I have the problems with rotator cuff penetrating tear. In that moment, certainly a part of the sport vis goes also inside the joints. But the patients are satisfied, the pain is going down also intra-articularly, not only extra-articularly. But it's not focused intra-articular, but it should be used in both situations, in special situations.
Maybe I have a very short answer for your question. But HA has many hyaluronic acid has many applications. 3 biggest areas. One is intraarticular, one is dermophilic, aesthetic, one is ophthalmic. But nobody uses ophthalmic products intraarticularly. Nobody uses intraarticular product for dermophilic. Nobody mixes them up. So there must be good reasons behind why you cannot use one for other indications.
Can we use it post-operative arthroscopy?
It's not designed
soft
for
tissue. I did soft tissue, maybe repair or cleaning of the cartilage. So it is healing process. Can we use it?
You can, but it's not designed for this. You will not have the best results using this kind of product. We have all the different types of products. Now I will take the liberty to ask Dr. Fabio Krebs, who is a very well-known sports physician in Brazil, what are his thoughts about the use, because he has a very good and large experience using the product.
Well, I have used it in ankle sprain some patient with ankle sprain, and I had used two in partial Achilles rupture. When I used it, and we had a formulation of metrics so better than after, because some patients that I put as part of this had a 20% of the rupture of the Achilles tendon and the regeneration complete after, and with consistent tissues.
Okay, so far any more questions? No, then I would like to thank you everybody for the presence and the patience to hear, and I also would like to thank for the panelists for the high quality of the presentation, and I think we solved all the doubts of everybody. Thank you very much.